I did notice that there was a colon missing from my title. If you look at all the titles in this section, everything is dot, 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 colon, dot, dot, dot. And so I just wanted to point out that I did have a colon there because that was one of the requirements for these talks. So the way I want to talk about this is we're going to go back to an old friend, EGFR. I know you'll be discussing a lot of the EGFR agents this afternoon, but I just want to take a quick poll, I guess by hands. ASCO 2004. Can we just get a quick a show of hands of how many people were there? Okay, so good number. ASCO 2004 was memorable to me for two reasons. First of all, it was the first ASCO that I actually personally attended, so you can imagine how overwhelmed I was. But secondly, I remember going to a couple of lung cancer symposiums, and as you saw with the immunotherapy talk this morning, there are slides that tend to come up a lot, and that's inevitable because whenever you're at the peak of that emotional excitement of a target that Dr. Ramalingam showed that looked like a curve similar to another curve that that he didn't go into, but EGFR was really at the peak at that moment, and I remember virtually every slide, slide 2 or 3 of every presentation showed the percentage of overexpression of EGFR in different tumor types. So say lung cancer, 93% EGFR overexpression. Head and neck cancer, EGFR overexpression, 78%. And you could just go down the line. It was very, very high, colorectal, et cetera, et cetera. And, in retrospect, it's kind of silly that we thought that would be the appropriate target, knowing what we know now. But right now, I would say we're really on that upwards plateau of enlightenment, and I'm stealing a lot from Dr. Ramalingam's talk. He mentioned that, you remember, the EGFRs were super excited, then we had that trough of disillusionment, right, when the studies first came out with gefitinib and erlotinib. Some of them were positive, but the magnitude of benefit was very, very limited, and I think I remember feeling the air come out of everything. The EGFR was so exciting, and then all of a sudden the clinical results came out, and it was just like, oh, we expected a lot more. Obviously, let's fast forward 10 more years, 12 more years, and I believe now we really are on the upwards plateau of enlightenment. We are learning a lot more. It's not the expression of EGFR that's really important, but it's really the mutation, and now we're even, as our diagnostic resolution increases, right? We're not going from the lung, which is anatomy. We're not going from histology. We're not even talking about mutation, positive or negative. We're actually now getting to a point where if you have a T790M mutation, or if you have an exon 19 mutation, we're really kind of changing the diagnosis of lung cancer, right? Saying you have lung cancer is not very informative, but if you have, I have an EGFR mutation in exon 18, that's far more, accurate in terms of our precision, in terms of, how to diagnose our patients. And I feel like, what I'm going to talk about here is kind of an old friend, and it kind of got lost a little bit, and I'm hoping to, kind of bring it to light a little bit. And as my former, some of the speakers that came before me, we are actively, looking to accrue patients. So if any of you guys are interested, please come chat with me really quickly. So what I'm going to talk about is a product called BI 148 to 694. I'll be calling it 694 or BI 694, just for ease of use. It may be familiar to you as a compound called Hanmi 61713. ASCO 2014, there was a big EGFR session where ruxolitinib and osimertinib, I hope I pronounced those correctly, were discussed. And Hanmi was kind of the third product there. And what I'm going to when I talk about the clinical data from the phase 1, phase 2 studies, is I'm going to show you that some of that data was very early on, and hopefully I'll give you a better snapshot of where the efficacy of that agent looks like. So I'm just going to start with a little preclinical data. This is kind of standard stuff. You can see here that now we're not targeting EGFR, right? Expression doesn't matter. Really targeting, we're hitting the targets. Exon 19, the L858R. You can see there's more than 2 orders of magnitude specificity for the sensitizing mutations. This is in vivo or in vitro. Here, when we look at tumor models, very similar results, right? You see we have examples where we use some of the other third-generation TKIs, and in mouse models you get nice tumor burden reductions for both models here. The mutations here, and in the wild type you can see there's a lot less. In the red is the 3 different dosing for the BI694, and then green is the AZD different doses. So I'm just going to pan over this. Preclinical data look very, very promising. A lot of this shows that it lays down the scientific rationale for looking at EGFR mutation specific targeting in lung cancer. So I'm going to just go over the clinical experience really quickly. Now, a lot of this, you have to remember, started out in a Korean biotech company called Hanmi, and when we had discussions with them, it was funny because they kind of presented the data in 3 different batches, and we feel that it was probably a little bit confusing. But the 3 different batches are, there was a dose escalation portion, so basically they looked at different doses, and they looked at, basically they're trying to identify the MTD, and they also looked at some clinical responses. Expansion part 1 was a 300 milligram dose. This is the one that was presented at ASCO 2014. You'll remember that response rates were were pretty much lower than what you saw with ruxolitinib and osimertinib. And essentially, this was the first dose expansion cohort. As we continued moving up in the dosage, we did do an expansion cohort of 800 milligrams. This is the recommended phase 2 dosage that we're moving forward with, and I'll get to that study in just a moment. So inclusion criteria for the phase 2 expansion cohort was very specific. It was basically patients did have to have that confirmed T79 mutation. This is very similar to the AURA study and the TIGER-2 study for ruxolitinib and osimertinib. So I'm just going to show you kind of baseline characteristics of the patients, the 3 different portions of that phase 1, phase 2 study. Here's the dose escalation. We had about 50 patients. We had about 83 patients. This is the data that was presented at ASCO 2014. And this is a little bit more updated data that was made available this year and then recently updated and will be presented next week at ASCO, ESMO Asia. I'll just talk about this is at 100 mgs, and this is kind of the nice images that people like to see that kind of really give kind of a good feeling about the drug. But this is basically updated data up until this mid-year this year, and then we've also did an updated analysis 3 months later, so that's updated to about August, July of 2015. And what you can see here is some nice waterfall plots. All these stars basically are ongoing, so we haven't reached, these patients haven't ended yet. And the response rates was about 55%. Disease control rate 95%. Obviously, still a little bit early. You can see most of the patients are still on treatment and continue treatment. And to point out, are these response rates real? We are very actively following up and continuing monitoring to see if they do have confirmed responses. You can see most of the responses, everything here with a small dot, is an ongoing objective response, and they're still on treatment. So we are actively following these patients and making sure that these responses are real and durable. I can say up until 2 months ago, the numbers haven't changed too much. The response rate's about 60% still. And then we have about 65 patients still ongoing responses. So this isn't weeks, so it's still a little bit early, but you can add about 8 more weeks to this, 10 more weeks, and we still have a lot of ongoing responses to this agent, BI-694. AEs, as you can expect, because of the selective nature of this agent, we're avoiding a lot of the EGFR-mediated toxicities. These are the things that we're seeing at the 800 milligram dose, about 60 patients. These are very comparable to what we see in the other third-generation EGFR TKIs. So just in summary, we think that this agent is very active in this patient. A lot of the patients are heavily pretreated. A lot of them obviously have EGFR TKIs, gefitinib or erlotinib first line. A lot of them actually, some of them even had chemotherapy as a second line. We have patients that even have up to 8 lines of therapy. Our registrational program is underway. It's a phase 2 study. We just named it. It's called ALUXA-1, and I can't tell you how we got to that. Our people get together and figure out some clever acronym, but it's called ALUXA-1, and that information is all available on clinicaltrials.gov. So I see my time's up, and you guys are probably hungry, so I'll stop there, and if there's any questions, I'm happy to take them. Sorry. So again, so it's like some of the other drugs we are looking there. It will say probably, but none of that's confirmed. So the patients, if they had CNS metastases, are allowed as long as they're asymptomatic, and there there's some case studies where they show some lesion responses, but that's all just anecdotal at this point.
If there are no more questions, we'll adjourn and we'll see you later this evening. Thank you.